yet. I'm Jana. I'm a postdoc in Peter Klimek's group at the Medical University and the Complexity Science Hub Vienna. I also work quite closely with David's group on social media topics. And so basically my research focus is everything that has to do with digital health. Research topics, applications that try to improve health through a range of methods that are available in the digital sphere. Today, I'm going to talk about agent-based simulations for optimized prevention of the spread of COVID in nursing homes. And sadly, as those of you who follow the Austrian news might have noticed, this is quite a timely topic because in the last couple of weeks, the infections in nursing homes have been skyrocketing. And this is becoming a real serious problem at the moment. So yeah, with this, I'm already in my motivation for this work. Why is it so important to look specifically at the spread of COVID in nursing homes? Well, first of all, patients that contract COVID that are as old as the people in nursing homes have a very, very high mortality. On the right, you can see the mortality over age. And as you can see, as you approach 80 plus years and people have more and more preconditions, the mortality skyrockets. Here it's 15%. In Austria, it's actually more like 30%. So 1 in 3 infection cases in a nursing home will lead to death. Secondly, there's actually quite close living conditions in nursing homes. People share rooms, people regularly interact, people also interact with their caretakers who have quite close physical contact to take care of them, clean them, help them in their daily lives. And that also facilitates spread of such an infectious disease quite a lot. And lastly, I think this topic is also very important because it becomes more and more apparent that we cannot simply lock down all the nursing homes and prevent visits and basically lock up the residents, because there's something like human rights. You can't simply lock up people against their will, and quality of life has to be considered as an important factor in this equation. So we have to find strategies that keep outbreaks and infections in nursing homes in check without treating the residents like prisoners. So to sum this up, this is also the outline of the remainder of my talk. The aim is to use agent-based simulations of residents and employees in nursing homes in a model that is calibrated to the situation in Austrian nursing homes to find the best prevention strategy. Now, let's start with the agent-based simulations. What is it I actually do? As I already said, I look at 2 types of agents that are the most important groups of people that are present in nursing homes. One of them, of course, are the residents, and the second group are the employees. All these agents can have an infection state, so they can carry an infection and then they can interact with other agents and transmit this infection. Now, for those of you who haven't done too much COVID research in the last weeks, here is a short one-on-one of how a COVID infection progresses in time. What you can see on the x-axis is the days since transmission. Day 0 is a transmission of a disease. And what you can see on the y-axis is the viral load in a microliter of swab on the logarithmic axis. So you can see that at first it's basically not detectable, and then the viral load rises exponentially, peaks at around 6 days after transmission, and then tapers off. And we try to map this viral load trajectory into agent states that we can then model. So we start out with susceptible agents. At the beginning, every agent is susceptible to the disease. And as soon as an infection is transmitted to them, they are considered to be exposed. Then it takes about 4 days for an exposed agent to become infectious themselves and therefore be able to transmit the infection to other agents. From day 4, it takes another 2 days until symptoms develop. So agents are usually already 2 days infectious before they even may experience symptoms. And now, as you know, one of the big problems with this particular disease is that only a smaller fraction of people actually start showing symptoms. So about 60% of people never show symptoms, but are still highly infectious. The amount of virus these asymptomatic people carry and spread is the same as the symptomatic ones. Now, from this point on, it takes another approximately 5 days until the viral load drops to a level where the people are not able to infect other people anymore. Of course, these are ballpark numbers. These are obviously distributions, and we just take the median of these distributions here to map this to the agent states. And now, of course, for each of those states, we also implement the possibility for an agent to be quarantined. And in quarantine, agents still undergo all these transitions because time still passes, of course, but they don't interact with other agents anymore if they're sitting in quarantine. Now, this is the basic model. This is what our agents do. And now we need to put this model into the premises of a nursing home. To depict what happens in actual nursing homes as accurately as possible, we have a collaboration with Karitas. Karitas is one of the largest providers of nursing homes in Austria, and especially, I think, in and around Vienna, they have quite a few. And they gave us detailed information both on the daily routines in these homes, as well as on the potential contacts that happen between residents and other residents and employees in these homes. Now, how does such a nursing home actually look like? This is a bit of an abstracted floor plan of an actual section of a larger Austrian nursing home. In German, this would be Wohnbereich. And what you can see in red are living areas of the residents. You can already see that this is quite a crowded environment. So you can see here to the right, there are rooms that are actually shared by 3 residents. Then here in the middle part, there are double rooms that share a bathroom with another double room. And then there are also a number of single rooms. But you can already imagine that there is ample opportunity for roommates to spread a disease to each other. Then in orange, these are shared living areas, common areas where residents can move around freely and can interact and also do so. They walk around and they talk to each other and they have friends. And this way they can also obviously pass around an infection to everybody else who lives in the same section as they do. And the blue areas are staff facilities, stuff like kitchens, doctor's offices, stuff like that. And such a section of a nursing home typically houses around 30 to 40 residents. This picture is 34 and is staffed by around 18 employees who are in close contact to each of the residents every day. Now we can abstract these contact types that arise in daily life in such a nursing home into something that I call contact intensities. First of all, of course, residents that share a room have quite a high contact intensity. They spend a lot of time next to each other, for example, while sleeping. They breathe out aerosols that can carry virus, and they fill up the whole room they share with these aerosols, and therefore contact to a room neighbor is considered a very close contact. Then there are shared tables at lunches. These tables are shared between 2 and 6 residents. And obviously during lunch, people talk, people don't wear masks, and people also exert lots of aerosol that could infect their table neighbors. These contacts we consider intermediate. This is actually also the same contact that employees have with residents. Employees usually wear masks, so this reduces the risk of spreading a disease a little bit, but still they have quite physical contact, close physical contact to the residents. And so we also consider this intermediate contact because a disease can still spread quite easily. And then, of course, there are these more or less random interactions of people that just meet in the hallways and talk for a bit. These interactions are usually shorter and people are surrounded by more air where the aerosols can spread. So we consider these contacts far contacts where the risk of spreading a disease is lowest. Now we can translate these interactions into something that's probably more familiar for the network scientists in our ranks, something like this. This is the abstracted contact network of the residents to the left, and the link strength is the intensity of the contact. And to the right, the dots to the right are employees, and the links or the interactions to the residents here are implicit. I didn't show them explicitly because every employee has contact to every resident and every other employee every day. This is just a snapshot of such a simulation, and where the agent states are visualized in different colors. Green is susceptible, yellow is exposed, red is infected, gray is recovered, and if a dot has a black circle, then the respective agent is in quarantine. Okay, now if we use this contact network and the agents that can have their infection states as explained earlier, and we introduce one infection through an employee, and then we let the simulation run, we get very typical curves that each of us will have seen by now, at least in the media. This is a typical SIR dynamics, where all the susceptible agents get infected over time. This is the green curve that drops, and the infected rise exponentially and then drop again as the supply of susceptible shrinks, and the recovered also rise over time. And in systems where the transmission risk is high enough and where there's no intervention, we will end up in a state where almost all of the population has undergone an infection by the end of the outbreak. This is to the left. You can see these curves for the residents, and to the right for the employees. It's basically the same. It's a bit rugged for the employees because there are fewer. Okay, now this is the basis of what happens if we do nothing. Now, what we want to do is we actually want to find out what the most efficient interventions are in such a system to prevent the spread of such an infection. Now, we have a couple of things that we can do to intervene. First of all, we have diagnostic testing. So if an agent shows the typical COVID infection symptoms like dry cough, loss of smell, fatigue, fever, we can test this agent. If the agent returns a positive result, we can quarantine all the contacts of this agent because there is a high risk that they will have contracted the disease by that point in time, and it's good to quarantine them to prevent the spread of the infection. And what we can also do is we can implement a preventive testing strategy, meaning that we do regular screens of all agents without a positive diagnosis first. So we just do tests to detect infections in advance. Now, to understand the intricacies of these interventions, I have to go a step back and talk to you about different test technologies, because they actually have quite a large impact on the results we will get if we implement these testing strategies. Now, you've already seen this curve of viral load in a patient that is infected with COVID, and different test technologies can detect an infection at different points in time. The PCR test is the most sensitive of all these tests and can detect an infection at a viral load of about 10 copies per microliter of swab, 10 virus copies. Then the next best thing is the so-called RT-LAMP test, which can detect viral load at about 100 copies. And the worst thing is the antigen test, which needs over 1,000 copies per microliter swab to detect an infection. Now, this translates to a reality that means that PCR tests can detect an infection before an agent becomes infectious. They can detect the infection at about day 3 after transmission. Just to remind you, patient becomes infectious at about day 4. The RT-LAMP test detects infectious patients when they are infectious. So they start, their detection threshold is about the viral load threshold that you need to infect somebody else. So RT-LAMP tests always detect you when you are infectious right now. And antigen tests detect after becoming infectious, because the viral load they need to return a positive result is actually above the viral load needed to be infectious. So they have about a window of 1 day after becoming infectious at first, where you're already infectious, but antigen will not detect you. And they have a window of about 2 to 3 days in the end of your infection, where antigen test will also test negative already, but you're still infectious. And the second intricacy of this testing technology is, of course, how fast they will return a result. As those of you who already got a PCR test might already have experienced, they are quite logistically challenging, because you need to take a swab, then this needs to go to a lab to be analyzed, and then the result needs to be returned to you. And depending on how overloaded the system is, this might take a couple of days to actually return a result. RT-LAMP tests are a bit easier, but they still need a lab to process, and they take about 1 day to return results. Also, RT-LAMP tests are not that common yet. They're more of an experimental technology, but are quite promising, I'd say. And then there's the antigen test, which is, of course, very nice and easy to use. It's like a pregnancy test. They take only minutes to return results, but of course you buy this speed by having less accurate results. Now, this return time of the result is important for quarantine decisions, because we only send contact persons of infected people into quarantine if we get a positive result. So if we have to wait 2 days to actually get a result, those contacts of the potentially infected person might run around another 2 days and already infect other people. Whereas if we get the result immediately, we can immediately start quarantining the K1 contact persons, and therefore, make the outbreak smaller. Now, to make the simulation we run as close as possible to the nursing home situation, we first needed to calibrate our simulation, because there is actually a large unknown in our simulation that we haven't talked about yet, which is the transmission risk. This is something that is very, very hard to assess systematically, and we can only more or less assess it empirically by looking at the amount of infections, of follow-up infections, one infectious person will produce. So what we did is we simulated a scenario that was very close to the situation in nursing homes in the last months, and we tried to make our simulation reproduce the outbreaks, the recorded outbreak data of nursing homes as closely as possible. And the scenario that we used for these calibrations is an introduction of an index case through an employee. This is actually the reality in nursing homes. The vast majority of infections are brought into the homes through employees. We only do diagnostic testing, so we only test people who show symptoms. We use PCR tests that take 2 days to return results. And we quarantine close contacts after a confirmed infection, and close contacts are the roommates and table neighbors of a resident. Now, if we do that, we get simulations or curves that look like this. Similar to the curve I've shown you before, you can see the number of susceptibles dropping over time, the number of recovered rising over time. But what is new here is the blue curve. Those are the quarantined agents. And what is what is indicated in the vertical red lines here, those are screens. Because what we also add is that if we get a positive test result, we start testing all the residents and employees in the nursing home once. And by this, we will already detect quite a number of infections. And what the end result is that still quite a lot of residents get infected. This corresponds to the large outbreaks we have seen in nursing homes in the last months, where 2/3, half, or even all of the residents in a nursing home got infected in an outbreak. But we already managed to protect some fraction of residents that will not be infected within the course of this outbreak in the end. And what we do to calibrate the simulation is to adjust the transmission risk between agents in a way that we reproduce the data that we know. So here you can see all the dots in this graph. Those are the outbreaks that are on record for Austrian nursing homes. On the y-axis are the infected persons per outbreak. On the x-axis is the day since the first positive test. Blue are the infected employees, and red are the infected residents in a given outbreak. And the shaded areas, those are the areas in which our simulation operates after calibration. So these areas are, of course, quite a large span because these dynamics cover quite a large range of outcomes. You can detect infection instantly, then you will have 0 follow-up cases, or you fail to detect it and it starts spreading exponentially, then you will have quite a lot of infected persons in the end. But what is important here that the area covered by our simulation covers all the outbreaks that we have observed in the wild. So I'm quite confident that our simulation at least manages to reflect the reality in the nursing homes to some extent. What I've put down below the graph is the reproduction number, the basic reproduction number we measure in this now calibrated system, which is around 2.6 if we introduce the infection through an employee. This is on the lower end of reproduction numbers that are reported for COVID-19. And if we introduce the infection through a resident, the reproduction number is a bit higher, it's 4.8. And this can actually be explained by the quite close contacts between residents. So I think this is also sensible to have an outcome where this basic reproduction number is quite high for these very cramped living conditions. Okay, now on to our final part, the detection of, or the optimization of prevention strategies to achieve the minimum possible outbreak size in nursing homes. The baseline that we start from is what I just described. So only diagnostic testing and quarantine and one screen after a positive case was detected. And what we add on top of that is preventive screening, so independent of positive results, with different test technologies, PCR, antigen, RT-LAMP tests, and different result turnover times. The results that we get from these simulations, and that I will talk about in the next couple of slides, all look like this. This is a heat map that shows you the outbreak sizes for different scenarios. On the y-axis, I have a screening frequency of residents. These are the preventive screens. So I will screen all the residents every 2 days, every 3 days, once a week, or never. And on the x-axis, you have the same for employees. I will do a preventive screen of all employees, never, once a week, every 3 days, or every 2 days. And the color code here is the outbreak size. So how many follow-up cases will be caused by one infection that is introduced into the nursing home among the residents. I don't show follow-up cases among the employees to make the visualization simpler, and because I think outbreak size or follow-up cases in the residents are the more important observable here, because as I already said in the very beginning, the residents are the group of people that have this very, very high mortality risk and that are crucial to protect in this scenario. Now, what is quite obvious, the more screens we do, the more often we test, the smaller the outbreaks get. This is quite intuitive. And we get from outbreak sizes of about 6 or 7 here in the baseline scenario where we do not do any preventive screens, to outbreak sizes of about 1 or 2 in a scenario where we screen both groups, residents and the employees twice a week, every 2 days. Now, what is a bit less intuitive is that screening employees is more effective than screening residents. If you look at screening only employees every 2 days, we get to outbreak sizes of about 2 follow-up cases. If we do the same for residents, we screen only residents every 2 days and employees never, we get to outbreak sizes of around 5. Now, this becomes intuitive again if we consider how the index cases are introduced into the home. The index case is introduced through an employee. Therefore, if we screen the employees regularly, we also have a higher chance of nipping the outbreak in the bud and preventing transmission to any resident. Okay, now this is only one test technology and only one turnover time. This is what I've written on the top here. This was simulated using antigen tests that return the results on the same day. But we can also look at this type of outbreak sizes systematically. Sorry, I skipped over one slide. What we also get from these simulations, of course, is the number of tests that we need to sustain one given testing strategy. This is actually also quite an important parameter for the homes because they need to know how many tests they need to buy and conduct, and also to calculate the workload that will come from these testing strategies. And that's why I put these numbers on the tiles. These numbers are the number of tests per day per person that is needed to implement a given testing strategy. So in the baseline scenario where we do only reactive testing, only diagnostic testing, we need about 0.17 tests per day per person. And in the most intense scenario where we screen both agent groups every 2 days, we need about 0.39 tests per day per person. Okay, now what I was about to say, we can systematically screen different test technologies and different turnover times. And what you can see here is in the top row, we compare 3 test technologies that all have same day turnover. The leftmost column map is the same day antigen tests that I already showed you. In the middle are the LAMP tests, and on the right are the PCR tests. Now, quite obviously, if you use a test that can detect an infection earlier and longer, you will do better. The question here now is if this is logistically possible. If you manage to test all your employees in the morning with a PCR test and get the results in the afternoon, then this is the best thing you can do. In the top row is a scenario where we introduce the index case through an employee. In the bottom row is introduction of the index case through a resident. And quite obviously, if you introduce the index case through a resident, then screening the residents will be more effective. In scenarios where you screen the residents often, you will end up with the lowest outbreak sizes, whereas in scenarios where you screen the employees and don't screen the residents, you will get large outbreak sizes. Now, what is the most realistic setting in these scenarios? The most realistic setting, and what is now being implemented in nursing homes, is actually to screen all the employees twice a week, so every 3 days. Why is that? Well, first of all, I've already told you that the data shows that most of the index cases are introduced through the employees. So it makes sense to screen only the employees. But this has also a second upside, which is that you can test employees way more easy than residents, because employees, first of all, are educated in doing these kinds of things. They are educated nurses and they can do this. And the residents, as they might be quite old and might already be a bit confused, are sometimes very, very hard to test because they simply don't understand what's going on. And they really don't like to have a stick up their nose every second day. So yeah, if you can get by with only screening employees, that's quite a good thing. It makes this strategy way easier to implement. And as you can see, if you manage to test all the employees every 3 days with, for example, RT-LAMP tests, you already reduce outbreak sizes to 1 or 0. So this testing strategy is enough to obliterate outbreaks in nursing homes if you manage to implement it. Now, just for comparison's sake, because these testing technologies I show you on this slide all have same-day turnover, so they all yield test results on the same day, I show you how it looks like if you delay the test results. Sadly, the bottom is cut off here. I'm sorry for that. But yeah, on the bottom is the screening frequency of employees. So if you here compare the same test technology, which is PCR, but you vary the turnover time from same day on the left to 1 day in the middle to 2 days on the right, you see what it does to the system if you have to wait longer for test results. And as you can see in the 2 days case, it looks quite catastrophic. So there are basically no screening scenarios left except for the everybody every 2 days scenario in the top right, where you manage to reduce outbreak sizes to an acceptable size. I mean, of course, talking about acceptable is a bit cynical in this situation where we talk about people's lives and every outbreak is or every infected person is an infected person too much. But I think if you weigh quality of life versus the risk of being infected, the possibility of 0, maybe 1 follow-up case from an index case in a nursing home sounds like something that is acceptable. Whereas if you have 7, 8, maybe even more follow-up cases per index case in the home, that's too much. So yeah, these are basically the results I produced in my research. Yeah, the take-home message for the nursing homes, which is now also already being implemented, at least in the homes of the Karitas, is to screen all the employees every 3 days with a test that has same-day turnover and is quite accurate. And they actually use RT-LAMP tests for that because they managed to set up a collaboration with an institute that does this for them and makes this happen for them. And now they're gathering more and more experience in the implementation of this and the logistics, and they actually managed to reduce analysis time to hours. So they really get same-day results from these tests. Yeah, before I end my talk, a few technical notes for the more technically interested of you. What I used to implement the simulation, I did it in Python, and thankfully there is a library, MESA, that implements a basic skeleton of agent-based simulations in Python already that can be very easily extended. It already comes with out-of-the-box functionality for a lot of handy things like collecting data of your simulation or scheduling interaction of all your agents simultaneous or staggered. So if any of you is ever in the situation where they need to implement an agent-based simulation, I can really recommend using this. And then I also want to give you kind of an outlook or also a bit of an impression of what is happening right now. As I already said, the Karitas is in this moment implementing an optimized prevention strategy based on the results we have from our simulation in their homes and rolling it out to more and more homes. In the last weeks, using this preventive screening strategy, they've already identified 18 asymptomatic positive employees. Of those, 7 alone in the last week. And they have managed to isolate those employees with a maximum of 1 transmission to an employee, to a resident. So in most of these cases, they managed to isolate the employees before they could interact with residents and before they could transmit the infection. And in some of those cases, the infection was transmitted once. But this is already quite an improvement over the really huge outbreaks we've had in the homes before. Yeah, and there is obviously a follow-up study in the works with Karitas, because we're now in the situation where Karitas is rolling out this preventive strategy, but the other homes in Austria sadly are not yet. And so we are in the situation where we can actually compare how Karitas homes are faring in comparison to the other homes in a situation where we are in the middle of a second wave in Austria and the outbreaks in the homes are at an all-time high. Okay, now the summary of what I've told you, and after that you're allowed to ask questions. I've shown you agent-based simulations that are micro-calibrated to the situation in nursing homes, in Austrian nursing homes, given the living conditions and contexts that employees and residents have in these homes. And I have used these agent-based simulations together with a range of interventions that homes can do to arrive at an optimal prevention strategy. And this optimal prevention strategy looks like it is to test employees every 3 days using a high accuracy test like PCR or LAMP with a maximum of 1 day turnover, best same day result turnover. And the result, if this strategy is implemented, is a maximum of 1 follow-up infection per index case, which I think is quite a good outcome. If you're interested in the simulation, it's publicly available on GitHub, and there is, as of yesterday, also a preprint, and the study is under review.